Hi, we're going to go ahead and cover the abdomen, just the basics, and we'll cover it more in depth in a couple of weeks, but for now we're just going to be concerned about the KUB. So we're going to go over slides 1 through 35. So the abdominopelvic cavity extends from the diaphragm to the bony pelvis. It consists of two parts, the abdominal cavity, the larger superior cavity, and the pelvic cavity. The abdominopelvic cavity contains a stomach, small intestines, large intestines, liver, gallbladder, spleen, pancreas, and kidneys. It also contains the rectum, the sigmoid urinary bladder, and the reproductive organs. These all are part of the pelvic cavity. The abdominopelvic cavity consists of the peritoneum, which is a double-walled membranous sac that encloses the cavity. It has the inner layer, which is the visceral peritoneum, and the outer layer, which is the parietal peritoneum. The retroperitoneum is a space behind the peritoneum, and the kidneys and pancreas lie in this space. And here's a diagram of the lateral view of the cavity, the abdominopelvic cavity. And which of the following is located in the abdominal cavity? And the answer is D, spleen. And here's the procedural guidelines. So patient preparation, just make sure the patient takes everything off except their underwear. Make sure that they take any jewelry, piercings, necklaces, anything like that. Make sure you have the correct exposure technique, which is 85 kV collimator size. Generally, it's 14 by 17, and collimated to the patient size. Have your SID, use your markers, lead shielding when possible, and giving patient instructions, which is on expiration. Don't have to be concerned with the patient preparation for what we're discussing right now. Generally, the patient preparation is if they're going to have a barium enema, so you would give them a laxative, enemas. So just like I said, just remove artifacts from anatomy of interest and provide the gown. Exposure technique, non-contrast examinations require maximum soft tissue differentiation, moderate grayscale desired, and a KP range that is too high will overpenetrate substructures. Exposure technique, tissue structures used to determine effective technique, lower lemur border, psoas, muscles, kidneys, ribs, transverse processes of the lumbar vertebrae. The IR collimated field size textbook gives the guidelines. Use close collimation on the field to provide radiation protection and to improve image quality. SID 40 inches is a recommended SID, or 102 centimeters. ID markers, generally use on right side markers, but left side can also be used. We use a right side marker just because generally that's the side closest to us. Try not to digitally annotate your markers. Always try to use your markers with your initials. Shield pediatric patients of reproductive age. The guidelines are on 33 to 34. On abdomen, it's difficult to shield a female just because of where the ovaries lie. Male, you can shield them below the symphysis pubis, just under where your collimation light is on the bottom. Patient instructions can explain and demonstrate the positions. Exposure for abdominal procedures generally made at the end of expiration to avoid compression of organs. And the essential projections of the abdomen. Right now, we're just concerned about the AP, supine and upright positions, PA in the upright position. I'm not concerned right now about the lateral decubitus. Like I said, we'll go into more depth later on. Three-way abdomen is usually a supine, an upright, and then a chest x-ray. And like I said, we'll go more into that later on. So two-way abdomen series is usually an AP supine and an AP upright. AP abdomen is also referred to as a KUB. KUB is kidneys, ureters, and bladder. So the names AP abdomen and KUB are used interchangeably. So the patient position is supine without rotation. Support the knees to reduce the strain. The IR, you center to the iliac crest. Make sure that the symphysis pubis is included. The septal ray is perpendicular to the IR. And then enters patient on the mid-sagittal plane at the level of the iliac crest. You don't have to feel for the symphysis pubis, just as long as you have feel the iliac crest, make sure that your mid-sagittal plane is in line, you should be fine. Like I said, generally it's 14 by 17, then you collimate to the size of the patient. Smaller patients, you collimate 1 inch outside the skin shadow. And body habitus considerations, hyperesthetic patients may require 2 crosswise projections, and a taller patient may require a separate bladder image. Patient standing, you center 2 inches above the iliac crest, and that's to make sure that it includes the diaphragm. You're not so concerned including the bladder symphysis pubis on your upright. You would get that on your supine and your upright. You want to include diaphragm. But if the bladder is to be included on the upright, center to the iliac crest, horizontal centered IR for diaphragm. The enters patient on MSP at level 2 inches above the iliac crest. And same thing, collimate to the size of the patient. PA abdomen upright, PA reduced stomatal dose, and should be considered when the kidneys are not of primary interest. So the upright was anterior surface, contact with the vertical grid, weight evenly distributed on both feet, MSP center to the grid, and then you would center 2 inches above the iliac crest. Again, on the AP, the P abdomen, it's perpendicular, CR is perpendicular to the IR. Enters the patient MSP at level 2 inches above the iliac crest, and then collimate to the size of the patient. And we won't go into decubitus positions. So we'll move on to slide 43. I'll do some image evaluation of the abdomen. Essential projections. So the AP, there's going to be evidence of proper collimation. Area from the symphysis pubis to the upper abdomen. 2 images may be necessary if the patient is tall or wide. Either 2 crosswise or what we call the T. We discussed that in class. It's a crosswise of the kidneys and then a regular of the going at the iliac crest. So it's like a T. And proper patient alignment is ensured by the following. Centered the vertebral column, the ribs, pelvis, and hips equidistant to the edge of the image, or collimated borders on both sides. And for the supine, there's no rotation of the patient as demonstrated by the following. the spinous processes in the center of the lumbar vertebrae. The ischial spines of the pelvic symmetric if visible, and the ala or wings of the ilia are also symmetric. Soft tissue brightness and contrast showing the following: the lateral abdominal wall and peritoneal fat layer, the psoas muscles, the lower border of the liver and kidneys, and the inferior ribs, transverse processes of the lumbar vertebrae, the right or left marker visible but not lying over abdominal contents. And that's what your AP or KUB, AP abdomen supine should look like. Just showing just the very bottom of the symphysis pubis here. See the outline of the kidneys. Your spine is at MSP. You see good contrast between the bones and tissue. For the AP abdomen upright, evidence of proper collimation, it's the same criteria as the supine position, as well as seeing the diaphragm without motion. Brightness and contrast on upright similar to the supine position, marker indicating the upright. Not the best example, but you can see they have the markers. You wouldn't generally put the markers right in the middle. You would probably put the upright marker to the side, right above your marker, your right or left marker. You can put the arrow indicator. For the PA upright, the evaluation criteria are the same for the upright projections. So we're going to go ahead and stop here for your AP abdomen or KUB. So we're going to continue later on and go into the decubitus positions. Thank you.